will. Good morning, everybody. Thanks for attending. And my name is Anita Srivastava. I'm an addiction physician at St. Joe's at Unity Health in Toronto, and it's my pleasure to be able to introduce our speaker this morning. Speaking to us this morning about the extended release buprenorphine and opiate use disorder is Ainko Ramanathan, who's a pharmacist based in Hamilton. He has worked as a pharmacist for a number of years in the area of opiate use disorder. He worked for a while as a medical science liaison for Indivior and was in charge of educating physicians on the use of Sublocade and extended release buprenorphine. And for those of you who were at CSAM last year, you may remember that he presented a poster on the outcomes of long-term use of Sublocade or extended release buprenorphine. He's partnered with us, or partnered with Medify to provide education to pharmacists, and he's also going to be a guest lecturer at the School of Pharmacy at the University of Waterloo. Ainko, thank you very much for your time this morning and for your presentation. I'm looking forward to it. I also just a couple of announcements. You can talk in the chat room, and at the end I'll leave time for questions. And right now I'm just going to give you over to the stage, and I'm going to lead the stage.
Thank you for that wonderful introduction, Anita. Hi, everyone. As Anita said, my name is Ainko Ramanathan, and today I'll be presenting to you a summary of evidence to optimize the use of extended-release buprenorphine in opioid use disorder. Okay, so first I'd just like to provide some disclosures. This program has received no financial support. Potential for conflicts of interest. I used to work for Indivior as the medical science liaison. I have no financial or professional ties to Indivior at this time or any other pharmaceutical company, and have not received honorarium or funding for this presentation. I will only use generic names to describe medications unless appropriate to mention the brand name. So you may hear me say Bup XR or XR Bup or extended release buprenorphine interchangeably. And I'll be using these terms in lieu of the brand name Sublocade. Likewise, I'll be using SL Bup or Bup SL or sublingual buprenorphine, and that's just my replacement of the name Suboxone. Okay. So let's go through the learning objectives. After this presentation, my hope is that you'll gain awareness of evidence to explain current opioid use disorder management methods with Bup XR specifically. The topics that I'm going to go through include Bup XR pharmacokinetics, buprenorphine versus fentanyl interaction, dose equivalence of Bup sublingual versus Bup XR, and rapid initiation onto Bup extended release. This isn't a complete summary of what studies actually exist for this particular modality. I've chosen these particular studies specifically as I feel that they're the most relevant for your needs. I'm basing this off of inquiries I've seen on the listserv, as well as questions I frequently received during my time as a medical science liaison with Indivior. I'm not going to be critically appraising the studies in this presentation. Instead, I will share with you the key findings and some of the pearls of wisdom that may help you optimize the use of Bup XR in your work settings. I will mention limitations of those studies, though, so that the boundaries of applying these findings is more clear. Overall, my intention is that you will be exposed to evidence that will guide informed clinical decisions. In addition, what I would like for you to gain are ways to communicate this information with your patients. There are many patients out there who have heard of Bup XR, but they seem to have a word of mouth understanding of the treatment, which I find has made some hesitant to even considering it. The evidence you'll be presented in the following slides is information I've used personally to educate Bup XR with patients since returning to my position as a healthcare provider. And therefore, I feel like it might be useful for you as well. Okay, so I always like to, whenever I talk about buprenorphine in general, it's really important to establish the 3 pillars of buprenorphine, just the fundamentals of it, which are that it's a partial agonist, it has a ceiling effect, as opposed to other full agonists, or as opposed to full agonist opioids, which tend to have a linear dose response relationship, meaning as you go higher and higher in dose, you get a higher and higher effect. With buprenorphine, it's a partial agonist, so there is a ceiling effect where as you start to increase the dose, there will be a point where it starts to plateau. It has high affinity for the receptor. Essentially, that just means compared to other opioids, if you have high affinity for the receptor and you're available, there's a good likelihood that the buprenorphine will bind to that receptor. And it has slow dissociation from the receptor. This is another really important feature of buprenorphine. Comparing this to fentanyl, fentanyl is a great opioid when it comes to analgesia, but it has a fast on and off profile. Buprenorphine, on the other hand, has a fast on, but a very slow off. That's the difference there. Um, Knowing these properties is really helpful, and it can help to explain some really important clinical pearls of wisdom, such as the opioid blocking effects of buprenorphine, the nonlinear dose effect relationship, as I mentioned earlier, and even how and why precipitated withdrawal occurs. Okay, so talking about the buprenorphine dose effect relationship, what I've provided here is just a table that summarizes plasma concentration of buprenorphine, how that translates to receptor availability, and then what is the clinical outcome that comes with that. So what we have here is at the top, 1 nanogram per mil of buprenorphine in the blood translates to less than 50% mu opioid receptor availability. This just means that buprenorphine is likely to be occupying more than 50% of the receptors. And then in terms of the clinical outcome, relief of opioid withdrawal. If you double that plasma concentration, you don't necessarily double the amount of receptors that you've covered. It, the estimate is that you'll probably have about 70% coverage of those receptors, or there will be 30% of those receptors available to other opioids. But by doing so, you're able to control withdrawal and cravings. By increasing it to 3 nanogram per mil, you are then leaving about 20% of the receptors available to other opioids. But what they find is that this actually achieves blockade of non-medical typical dose of opioid. So essentially, non-analgesic uses of opioids. I have an asterisk on here though for a specific reason. And that is because these findings come from a review publication in 2014, and the sources of data that it uses originates prior to the prevalence of powdered fentanyl. So before I get into the limitation further, I'll just explain what those numbers mean on the left. So the 1, 2, and the 3 nanogram per mil, just to give you some context. So if someone was to receive a 100 milligram maintenance dose of buprenorphine XR, when you achieve steady state, the lowest possible level of buprenorphine that you're going to achieve is about 2 nanogram per mil. And the average concentration is about 3 nanogram per mil. For those who are given 300 milligrams as their maintenance dose, though, the minimum at steady state is about 5 nanogram per mil, and their average buprenorphine concentration is about 6.5 nanogram per mil. So you could say that essentially between 100 and 300, you're doubling up essentially how much buprenorphine you have available in the system. So let's talk about why that's even relevant. The limitation, as I discussed previously, is that these values and then therefore the outcomes seem to translate from data that existed prior to the rise of powdered fentanyl that we're seeing lately. So lately, observations from clinicians treating those users of illicit fentanyl is that BupXR doses reflective of what we see on this table are not achieving those outcomes. So there are many possible explanations for this. But what is clear is that targets previously mentioned in the literature that I have on the table above are subtherapeutic, which necessitates higher doses and sometimes more frequent BupXR dosing. It may therefore be valuable to revisit this in the context of the current illicit opioid supply to better understand. However, as clinicians, that's not something that we can do. So, since the above blood levels are reflective of 100 milligram maintenance, but the outcomes are inadequate for fentanyl users, it stands to reason that 300 milligrams may be more of an appropriate dose, and current practice reflects this. And further on into the presentation, I'll provide some more evidence that will actually strengthen that claim. Okay. So why lie to your patients? LAIs, long-acting injectables, why are we even considering that? We have oral options historically. Is it really necessary to give someone a long-acting injectable? So what I have here is an example from with using antipsychotics in schizophrenia for treating schizophrenia. It's a systematic review and meta-analysis that showed that LAIs, long-acting injectables, demonstrated significant benefit in the domains of preventing hospitalizations and relapse. And possible reasons for this include patient discontinuation of treatment from oral options. So It's not specific to addictions at all, but I chose to mention the study as it speaks to another mental health indications, which has its parallels to OUD and actually has started to incorporate a variety of LAIs. So in the scope, if we're talking about antipsychotics, like at least 3 or 4 different long-acting injectables for different molecules that already exist for antipsychotics. In OUD, we're not so privileged. We really only have one extended release LAI for OUD. Although there is another option that has recently been released into the US market, but it's not available in Canada at this time. Anyways, from my experience, I just find that patients are much more sensitive about their medications that treat their mental health and addictions and can notice some subtle differences that we may not expect or appreciate. And I compare this to physical ailments like hypertension or diabetes. So, as a pharmacist, it's very common to switch somebody from brand name to generic when a generic becomes available. And usually, this doesn't really become an issue for anyone if they have a physical ailment like hypertension or diabetes. However, more commonly, I do find that these switches tend to affect those who are using medications to treat mental health conditions, as well as with addictions. We also saw a similar effect happen when reconstituted methadone was switched to the pre-formulated methadone that we currently see today. So all that to say, formulation can make a difference, essentially. From this study, a possible explanation for why LAIs were found to be beneficial over their oral counterparts is that drug levels are maintained and slowly taper over the course of days or weeks. However, with oral options, they come with daily highs and lows, and in some patients, those daily low drug levels may not provide the therapeutic effect they need and potentially destabilizing them. So, what I'm trying to get across here is that the benefits of LAIs are not just limited to simply convenience, but also include the prolonged effects, which may translate to better outcomes, which was established here with antipsychotics. Okay, so based on that, what are some of the differences between sublingual buprenorphine and extended release buprenorphine? So I've put together this table here to just quickly summarize what some of those differences are. So first, let's look at the dosing frequency. For sublingual buprenorphine, based on the monograph, you can give it daily or every other day. In terms of extended release buprenorphine, though, you can give it monthly. What I want to make very clear, though, is I use the term dosing frequency. So with Bupixar, it's to be given monthly. But just one thing I want to make clear is that just because it's given monthly does not mean that by the end of that 1 month, you're down to 0 nanogram per mil of buprenorphine in the blood. It's not meant to last 1 month. In fact, it's actually meant to have an accumulation effect. And this is done to achieve steady state later on. So just something that's really clear to make clear to your patients, essentially. Don't tell them that it's going to last 1 month. Just say that they should be coming in monthly in order to achieve like the therapeutic level that they're supposed to get. Furthermore, let's talk about the peak onset. So with sublingual buprenorphine, it takes about 1.5 hours to reach its peak levels, although the onset of action is around 20 minutes or so. With extended release buprenorphine, though, it takes anywhere from 24 to 48 hours. For the half-life, sublingual buprenorphine is 24 to 42 hours. This to me as a pharmacist is interesting. I wouldn't have thought that because we have an extended release version that it would affect the half-life, but it actually does. So for an oral option, 24 to 42 hours, but when you switch to an extended release option, the half-life is 43 to 60 days. So what that means is that a single injection may still be present in the blood for as little as 5 months still. In terms of time to steady state, sublingual buprenorphine takes about 1 week to achieve that. With extended release buprenorphine, it takes about 4 to 6 injections or months, depending on if you're actually doing monthly versus a bit more of a rapid frequency. And then in terms of induction, you start people on 2 to 12 milligrams on day 1 with the sublingual buprenorphine, and you may increase to 16 milligrams on day 2. As opposed to with extended release buprenorphine, you have to give them a minimum of 7 days sublingual buprenorphine between the dose of 8 and 24 before proceeding to 2 monthly loading doses of 300 milligram injections of Bupixar. In terms of inductions, I'm fully aware that this is not what's typically done clinically now. where we're much more aggressive and rapid starts are preferred. There isn't strong evidence to tell you that this is safe. However, the studies that informed the monograph took place prior to the rise in fentanyl. So the discrepancy seen clinically is in response to the times. So overall, what I would say based on this slide here, yes, they do contain the same active ingredient, so they're going to have the same pharmacological effects, but the PK differences is key here. For extended release, it's going to be more prolonged essentially and delayed. Therefore, there are far less fluctuations in buprenorphine levels with the extended release formulation. In other words, less highs and lows to be experienced, and it's a prolonged effect. And this could be a more stable experience for the patient. So to address the comments I've made, repeatedly about highs and lows, let's take a look at what that actually looks like. So I've attached the following diagram from a CSAM poster that was presented last year. This compares sublingual buprenorphine concentrations to extended release buprenorphine in terms of peak, trough, and average concentrations. Overall, what you can see here is that the extended release buprenorphine provides buprenorphine at similar or higher levels than that is achieved with its oral counterparts. But a key difference is that the difference between peaks and troughs tends to be narrower, especially in the case of 100 milligram maintenance. So let's take a look at the graph just to actually see what I'm talking about here. As you increase the dose of your sublingual buprenorphine, understandably, the peak concentration is also going to increase. That's what we're expecting. So does the minimum concentration. But what you see is that the difference between peaks and troughs starts to increase as you increase the dose. In comparison, when you're at steady state with buprenorphine extended release, and let's say you're giving someone 100 milligrams monthly, the difference is a lot tighter. So the highs and lows are not so different. Another thing that's interesting here, and it's not something that's illustrated in the graph, is time as a variable. The peaks and troughs typically occur with each administration. So with sublingual buprenorphine patients may experience highs and lows daily, whereas with extended release buprenorphine, they will experience a peak maybe around day 1 or 2, and then a gradual taper off after. Um, in my experience, not all patients on sublingual buprenorphine complain of these highs and lows. So I'm not saying that just because they experience daily highs and lows that they're always going into withdrawal during the lows, but there are many that do. This is also not unique to buprenorphine. I find that there are many patients treated with methadone that experience withdrawals less than 24 hours when it's designed to be lasting 24 hours. Therefore, providing buprenorphine extended release may give some patients the sustained buprenorphine level that they need to avoid those feelings. Okay, so I hope what I've given you right now is a good foundation just to understand what is buprenorphine, how it kind of acts, and it should help with understanding the studies I'm about to discuss now. Okay, so the first study I want to discuss with you is the population pharmacokinetics of buprenorphine XR. This was a study that was, it was a publication that was released in 2021. To me, this is one of the most helpful studies to get a sense of timing and extent of buprenorphine availability when it comes to extended release buprenorphine. So, firstly, steady state depends on dose, and the dose can influence time to steady state, and as well as how much is in the plasma at that time, too. So here we get to visualize how long it takes to reach steady state, how much is in the blood. The top figure, so the graph at the top there, illustrates plasma levels that you're going to achieve if you give someone 100 milligrams as their maintenance dose versus if you gave them 300 milligrams as a maintenance dose in the lower graph. So my first observation when I look at this is time to steady state. If somebody is being maintained at 100 milligrams, they're going to stabilize quicker. I don't mean clinically stabilize, I just mean their plasma level will stabilize quicker. So clinically speaking, you will sooner understand the extent to which this dose can help a patient than with 300. I'll explain what that means. So with 100 milligram, you establish steady state essentially with one dose after loading. So if you give someone those two 300 milligram loading doses that you're expected to give, and then you give them 100 milligrams after that, you will have established steady state within a month. By then, you will get a sense of what dose is appropriate for the patient, and this is consistent with what's in the monograph. So essentially, by giving someone 100 milligrams after those first 2 loading doses of 300 milligrams, within a month of that 100 milligram dose, it'll be clear if that's going to be adequate enough for that patient. It also tells us that for those treated with 300 milligram monthly injections, full therapeutic effects may take 6 or 7 injections before the concentration reaches steady state, or cruising altitude, as I put it. So if the decision is made, let's say, to treat with 300 milligram monthly, um, but maybe by injection 2, 3, or 4, the patient feels like they're not getting they're getting an inadequate response. And by inadequate response, I'm mostly referring to craving and withdrawal control. So if at that point, a decision is made to discontinue sooner than those 6 to 7 injections that it may take to reach steady state, um, it may be premature since it hasn't reached its maximum drug level. So essentially what I'm suggesting is if somebody is getting 300 milligrams as a maintenance dose, it's worth riding it out at least 6 or 7 injections just to get a full appreciation of what it's capable of. By discontinuing it sooner, you may be cutting it short, essentially. Discontinuation after steady state is steady, and benefits of treatment are prolonged long after discontinuation, and that's relative to oral OAT options. So if you were to discontinue 100 milligram maintenance after steady state, the BUP levels are still at therapeutic levels for 2 months beyond that. So let's just take a look at what I'm referring to here. Essentially, once you reach steady state with the 100 milligram maintenance dose, and let's say the patient was to stop attending or there was a decision to discontinue treatment after that, you're still receiving therapeutic levels of buprenorphine up to 2 months later. Okay, so hold on, let me just get to my notes again here. So in patients who experience relief of symptoms, let's say at 1 nanogram per mil, though, it's conceivable that they may experience relief for longer than that. Whereas in the case of 300 milligrams in the lower graph, as you see, after 9 consecutive injections based on these figures, therapeutic levels of buprenorphine can still be seen in the blood for after 5 months. So I like to bring this point up with patients all the time. I tell them this so that just to illustrate a few things. One, that they won't experience a sharp drop in symptom relief if they miss a day or even a few weeks of treatment. And this is very relieving for many who experience withdrawal less than 24 hours after a daily dose of OAT. This is also a crucial safety mechanism as treatment discontinuation can be followed by relapse and overdose. And in further slides, I will discuss how these BUP levels that I'm talking about may prevent that. Just to give you an anecdote, I encountered a patient who had gone 60 days between injections. So they had essentially missed the injection that they were supposed to get during one of the months and then just showed up for the next injection. They were maintained on 300 milligrams, so their plasma levels are probably more reflective of what's going on in the lower graph. But in that time between injections, he had used or smoked fentanyl multiple times. He did not experience euphoria and did not experience any respiratory depression effects, and he certainly didn't overdose. I would not expect this from any other OAT option, especially the oral OAT options. So this data can also inform clinicians of what might be expected if using BUP-XR to taper patients off treatment. Not that I'm suggesting that you do that. It is considered off-label, and there's also not enough evidence to support that this is a safe way to do it. However, if one was to use this type of graph is actually going to be a great way to illustrate what might happen. In summary, buprenorphine XR PK can help explain its clinical advantages as opposed to the oral OAT options. Okay, so this figure is a bit more granular and gives a view that's understanding what's happening week to week compared to the previous slide where I had things month to month. The reason I'm bringing this up is I've recently come to find that there are patients treated with buprenorphine XR that are requiring weekly injections during their stabilization phase. Again, off-label, it's still supposed to be only once monthly. However, what clinicians are telling me is that without this frequency, these particular patients are destabilizing and returning to use. A possible explanation for this phenomenon is that the peak may be what contributes to those initial benefits. and the patient is experiencing, but this only lasts about 1 week, and then the bup levels drop and flatten out at nearly trough levels. So let's take a look at what I'm referring to here. For those particular patients who seem to be benefiting from the injection, but just only for a week, what they're experiencing here is that peak that they get, but then after that week, we start to plateau. And then it stays that way for the remaining 4 weeks until you get the next injection. So, which is why it seems that some people are getting weekly injections in order to avoid those drops. Um, Important to know though, weekly buprenorphine XR injections is relatively new. I'm not aware of any evidence to back this up. So without evidence, it's unclear what are the risks in lieu of the benefits. Okay, transitioning from sublingual buprenorphine to extended release buprenorphine. So the following table informs clinicians of the relative difference between sublingual buprenorphine and extended release buprenorphine, and I'll go into some more detail. So this is a table that was presented on a poster last year at CSAM as well. It helps you understand essentially what is the equivalence of a dose of sublingual buprenorphine versus an extended release buprenorphine. And I feel like it can help make more informed decisions when considering those transitions from one to the other. It does this by comparing essentially the relative differences in peaks, troughs, and average concentrations. Uh, I'm going to explain what these numbers mean though. So previously whenever I brought up the numbers of buprenorphine, I was saying, 1 nanogram per mil, 2 nanogram per mil, 3 nanogram per mil. On this slide, you're seeing numbers that don't look anything like that. And that's because this is not the actual plasma concentrations. The best way to understand it is that these numbers are actual multiplication factors to understand the relative difference between sublingual and extended release buprenorphine. So let me just explain what that actually means. Let's look at table 2 on the bottom, and let's look at 2 milligrams. So by looking at this, what we can see is if someone was dosed daily with 2 milligrams of sublingual buprenorphine, and then you were to give them 300 milligrams of Bup-XR, what would happen is that the maximum concentration that they would be getting from that injection is 3 times higher than the max that they would experience on the sublingual version. And then the average concentration also roughly the same thing, about 3 times that of the oral option. So knowing this, it can help to interpret the rest of the table as well. Now, per product monograph, 8 to 24 milligrams is the recommended dose range to switch from sublingual to extended release buprenorphine. Now, table 2 is going to be really helpful for this next part. So last year, the Buprenorphine XR monograph was updated in July, and it informs that not all patients actually need to be given those 2 consecutive 300 milligram loading doses. 8 to 18 milligrams of sublingual buprenorphine can be transitioned to only 1 300 milligram injection, and then following that 100 milligrams maintenance. So that's a lot less than the typical 2 loading doses of 300. Who this could be helpful for is when considering the needs of some patients who find that the lump is intolerable, or the pain from the injection process is unbearable, or for those with low adipose tissue, which is a practical barrier to administration. So between the 300 and the 100 milligram injection, the 300 milligram is logically 3 times higher in terms of volume. So for someone with low adipose tissue, it's nice to be able to use a smaller amount essentially. Another pearl here is that some patients hear the number 300 milligrams or even 100 milligrams, and in comparison to their oral dose, it sounds substantially higher than what they normally get, even though it is spread out over the course of a month. So I like to use this information and I simplify it for patients to explain that the amount of buprenorphine in their blood from the oral option is very close to what they will achieve with the extended release option. But the difference is that this is achieved with 1 administration monthly as opposed to daily administrations. If considering extended release buprenorphine for those below 8 milligrams, it is essential to know that what you're doing is not recommended and is off label if you were to give Bup-XR to patients below 8 milligrams. However, If you made the decision to treat with Bup-XR in these circumstances, using the information from this chart may be a helpful resource to understand relatively how much more or less buprenorphine you are giving to those patients. So there was a case actually where something like this did happen. So there was a case where a patient was maintained on a dose of 2 milligrams historically, but they were going on a visit to a country that doesn't allow them to bring narcotics. So that means that they couldn't bring their carries without it being illegal. The decision was made to give them extended release buprenorphine, but they chose 100 milligrams. And the patient tolerated this well. There were no withdrawals or cravings reported, and they transitioned back to oral dose when they came back. So let's see what may have helped inform that decision. So again, the patient was receiving 2 milligrams daily, and the decision was made to give them 100 milligrams. So what was achieved essentially by giving them 100 milligrams was essentially just a mere 10% increase in buprenorphine when we look at the maximum concentration and then the average concentration as well. So clinically, that's not a huge jump, and it's understandable why the clinician thought then it would be okay to give them 100 milligrams, and good to know that the patient also tolerated it well and there was no adverse events from it. If you're going to use this approach, though, in my opinion, it would be preferable if the trough concentration that you're going to get from the extended release buprenorphine is equal or at least greater than the sublingual buprenorphine troughs, so that the patient doesn't experience lower concentrations than they are used to. So essentially, we want to make sure that they don't go into withdrawal. And also that the max concentration does not greatly exceed that of sublingual buprenorphine. I don't have a benchmark for what qualifies as greatly exceeding it, so it's up to your clinical judgment. But overall, there may be some flexibility for who can get Bup-XR, but with discretion. I think that if the difference is too great, it's best to just continue with sublingual tablets in that case, though. Okay, so this is a really important study as well that looks at the interaction between buprenorphine and fentanyl. It is mentioned in the monograph, although very briefly. There aren't a lot of details, so I'm going to expand on that. So the following figure that I have here comes from a poster that was presented last year at CSAM. So clearly, if you didn't go to CSAM last year, you missed out on a lot. But let me just give some context as to why the study happened. So previous to the study, there was no direct assessment to establish that buprenorphine's opioid blockade effect also results in protection against respiratory depression from other opioids like fentanyl. This has been known anecdotally, but the rate and extent to which was not known. So this study, the way it was designed, it's an open label crossover study. There were only 8 opioid tolerant participants, so it's not very big. And it compared fentanyl-induced respiratory depression with or without the presence of buprenorphine. So just to give you an idea of like how they designed the study, on day 1, those 8 opioid tolerant subjects were brought into the lab. They were given a placebo, and then they were given fentanyl at 4 escalating doses that were scheduled. And what they did was they had a mask on them to measure their minute ventilation or to get an understanding of, is it causing respiratory depression or not. So during that placebo day, essentially none of the patients were able to proceed to the 4th and final dose of fentanyl. On day 2 there was a washout period, and then on day 3 they were given buprenorphine instead of the placebo, and then 2 hours later they were given fentanyl, and they were just trying to assess essentially, did the buprenorphine beforehand have a mitigating effect on minute ventilation. In terms of how much buprenorphine they gave, they used concentrations that were same or similar to that of Bup-XR at steady state, specifically the minimum concentrations. But important to note, the actual Bup-XR itself or even sublingual buprenorphine were not used. They used an infusion of buprenorphine to mimic the concentrations that you would get at steady state, essentially. But more so the minimum concentration that they say. So in other words, the concentrations that they used here is a conservative underestimate of what Bup-XR could do at steady state for these patients. So if we look at the columns, the middle column reflects 100 milligram maintenance dose at steady state, but more specifically at its minimum. And the last column on the right reflects 300 milligrams steady state, again at the minimum. So an important limitation to just disclose here, besides the fact that there are only 8 subjects used in the study, the amount of fentanyl used in the study is not nearly the same as what one might find on the streets of Toronto. Therefore, a clear recommendation based on this study cannot be made. However, it is worth knowing that the amount of fentanyl given to these opioid tolerant subjects was enough to cause respiratory depression when they did not have buprenorphine on board. So when they were just given a placebo and then given, um, fentanyl, despite the fact that they do have some level of opioid tolerance, they all experienced respiratory depression that required medical intervention during that placebo phase. However, when during the crossover period, when buprenorphine was given, there were no respiratory depression events that occurred. O2 sats were maintained. Those who received concentrations reflective of 300 milligrams, which is like, again, our values over onto the far right, they experienced less changes in minute ventilations despite the escalating doses. So just to summarize, the columns here depict 3 different buprenorphine levels that were assessed. The first row depicts day 3 of the study, or the crossover day. Again, buprenorphine was given 2 hours prior to the first fentanyl bolus doses. With escalating fentanyl doses, you can see the changes in the minute ventilation in the bottom row. But what's valuable to see here is that the higher the buprenorphine level, the less of an effect fentanyl has on ventilation. That, I think, is the real pearl of wisdom here. Buprenorphine receptor binding is also less affected by fentanyl when this is the case. All in all, buprenorphine appears to have a dose-dependent protection, and I put that in quotations, effect against fentanyl-induced respiratory depression. So clinically speaking, if the aim is to prevent overdoses in a patient who may be exposed to fentanyl intentionally or unintentionally, then being too low carries a risk, even if their withdrawals and cravings are well supported. So do you remember the patient I mentioned earlier? He's being maintained on 300 milligrams of, Bup-XR. His cravings and withdrawals were well maintained. So one might think, could we just step down to 100 milligrams? However, despite the fact that his cravings and withdrawals were maintained or were controlled, he still happened to use fentanyl. I asked him, why did you use fentanyl if that's the case, if you're not feeling, withdrawals or cravings? What he had told me was interesting. He actually just said he kind of just missed the habit of doing it. He missed even the taste of smoking it. So all that to say, even though someone is on treatment, they may, unintentionally or intentionally be exposed to fentanyl. And therefore, if they have more buprenorphine on board, it may have a better chance of protecting them from overdose. I think it's important to get this point across, as there are many myths about buprenorphine generally speaking, but few understand this particular phenomenon. In particular, that bup is not for fentanyl users is a myth I often hear, or that bup is more appropriate for those who are more likely to achieve abstinence. This is not something that's mentioned in the guidelines. However, it's just a rhetoric that's widely spread, and I've heard it from many. Personally, what I do is I've used an analogy that bup acts like a bulletproof vest, and this seems to resonate with a lot of patients. However, in patients who are adherent and abstinent to uh, who are abstinent and not willing to use opioids outside of their OAT option, this measure may not be so necessary, and you could consider just giving them 100 milligrams or just even the sublingual buprenorphine tablets. Okay, and the last study that I want to discuss is rapid initiation or same-day starts. So this study was presented at CPDD in 2021. It's titled "Initiating Monthly Buprenorphine Injection After a Single Dose of Sublingual Buprenorphine." And so basically, as the study states, what they wanted to do was see if you could achieve safety when giving buprenorphine XR on the same day after a single dose of sublingual buprenorphine. So right off the bat, this breaks all the rules of the monograph. Okay, what the first one, of course, being the timing of the dose, and I'll go into some of the specifics about that. But let me go into specifics of the study first of all. So if you actually look at even the Suboxone monograph, it suggests that you shouldn't induct someone until their COWS score is above 13. In this case, they wanted to just make sure that their COWS score was above 8. The dose of buprenorphine before getting extended release buprenorphine was only 4 milligrams, whereas in the monograph, it suggests that someone needs to be stabilized on 8 to 24 milligrams. So this 4 milligram dose was really just a test dose. It was essentially just to make sure that there was no allergic response to the drug, no precipitated withdrawal, or no excessive sedation. But it kind of helps to shatter some of the concerns or conservative approaches that someone might take when giving buprenorphine XR, simply because based on the monograph, it almost makes it seem like you have to gain some sort of tolerance to buprenorphine before getting Bup XR. Whereas with this, they gave a low dose buprenorphine and then immediately give extended release buprenorphine. In terms of the timing, I do say that they give it on the first day, but actually they give the 4 milligram dose of sublingual buprenorphine, and provided that that the dose is well tolerated, there's no anaphylactic response, they gave them 300 milligrams of Bup XR as early as 1 hour later. So, overall, it's a very aggressive protocol compared to what the monograph suggests. But was it safe in the end? So overall, it aimed to assess if this protocol was going to be safe. In terms of who was in it, they had 24 treatment-seeking participants. 70% had fentanyl in their urine at baseline. So that's a little bit more reflective of what we see clinically. 25% of all participants were using drugs via the IV route. They did have to have abstained from opioids prior to by at least 24 hours or 6 hours, depending on if it's a long-acting or short-acting opioid. Um, and in terms of the results, it wasn't without adverse events, so I won't say that it was completely smooth. However, all severe adverse events that occurred within the first 48 hours, and there were no deaths. In terms of what was considered a severe adverse events, these were things like irritability, pain, chills, and vomiting. And these were managed with supplementary medications such as trazodone, ondansetron, and NSAIDs. There were 2 events of precipitated withdrawal that did occur, but this did not stop those particular patients from completing the study. Overall, the study demonstrated that this population may safely tolerate Bup XR when started on the first day. I wouldn't generalize and say that all patients could be started on buprenorphine XR on the first day. However, the Transform trial, which is currently underway, does compare rapid versus traditional induction methods, and this may provide a bit more of a robust recommendation as to whether we can dose so early. Most recently, there was actually a study that was released. It's titled Real World Evidence for Impact of Opioid Agonist Therapy on Non-Fatal Overdose in Patients with Opioid Use Disorder during the COVID-19 pandemic. It's a big mouthful. I just refer to it as the overdose study. I'm very happy to see that it has been published. In fact, I know some of the authors personally, so it's really great to see these results. It's a Canadian-wide study that compared overdose outcomes between methadone, buprenorphine sublingual, and buprenorphine XR. Essentially, just to say that when on treatment, what was the likelihood or the frequency of non-fatal overdoses while on treatment? So not overdoses due to the treatment, just overdoses due to outside use. This is a first of its kind trial, and therefore it adds to the body of evidence on this particular subject. It's a retrospective observational trial. The baseline characteristics of the patients were unbalanced, so it's important to keep that in mind. However, when risk adjusted, buprenorphine XR was found to be superior to methadone for the prevention of non-fatal overdose. So given these findings, a future RCT could provide clinicians with more robust evidence to understand which modality is superior. However, it's really nice to see that this type of data is available now. So in summary, and I'm going to leave some recommendations, Bup XR is a distinct treatment option from sublingual buprenorphine. There are less highs and lows, and it has a sustained plasma concentration. Bup XR is a useful tool for treating patients with OUD. It interferes with other opioids from binding and appears to have a protection effect. However, those who desire the drug-liking effects of opioids may find that this is not the right option for them. But I would like to add at this time. Bup XR may provide a smoother OAT discontinuation process than traditional taper methods. And there is currently a study underway that's going to be assessing this. And higher Bup XR maintenance dose, 300 milligrams, is a better option than 100 milligrams for those who use fentanyl. If safe and necessary, Bupixar can also be initiated as early as day 1. So that concludes my presentation. If you have any questions, I'd be happy to take them.
Thank you very much. That was such an informative talk. There have been a bunch of questions in the chat, so I'm just going to read out a couple of them.
Sure.
So one of the questions was, Harvey is asking, in the original studies, was there any data about the maximum amount that could be given sublingually on day 1 of induction? So was it 16, 32, 24 for the first day of any sublingual induction?
So from what I recall in like those original studies, 24 milligrams was likely the maximum that they were giving. This was also based on the fact that they didn't feel that there was going to be added benefit beyond 24 milligrams. But like I said, this is based on patients who were not using fentanyl at that time. So this is to me, I find that this is outdated and it's out of context. These days, we find patients are not getting adequate results from 24 milligrams, but then they start to actually find relief at 32 or even as high as, I don't know, I've heard 56 from some people. So that's why I say that, some of the monograph information is a little bit out of date and it's out of context as well.
Thank you. And then there's another question which I think you may have answered. The question was, is methadone as protective as buprenorphine, extended release and being protective against overdose? And I guess Kenley's study somewhat answered that question.
Yeah, I think it somewhat answers that. I think an RCT would be the best way to actually assess that. I mean, we do know that methadone has a protectant effect. It's just that it protects in a different way, right? So methadone or even other forms of full agonist therapies, the way that they provide benefit in this way is that they just help with maintaining tolerance so that you don't overdose should you be exposed. Buprenorphine, on the other hand, it's not really necessarily to do with tolerance, more so to the fact that it's just blocking the opioid receptor, so that should fentanyl be in circulation, it's just not able to do its job essentially.
Okay, great, thank you. And speaking of methadone, there's a question around transitioning from methadone to extended release buprenorphine and any strategies for that. And there's a couple of comments on somebody using morphine or slow release morphine in the interim as well to help with that.
Yeah, I mean, I wish I had more like robust evidence to share to actually say what can actually be done. I think this is something that the folks in Timmins have been achieving, though, with their macrodosing strategy. Of course, it does help to have things in a more controlled setting so you can actually achieve those outcomes. The other one that I'm hearing from a lot of people is using Cadian for bridging. Again, I don't know what the success rates of it are, but these are just multiple strategies that people are trying. And the other one, of course, traditionally speaking, we use is microdosing as well. Yeah.
Thank you. And there's so many questions, so I'm just going to try and get to all of them. And sorry if I don't.
That's okay.
There's a question around: can you continue to give sublingual buprenorphine once the person is on extended release buprenorphine?
So it's not recommended, at least on the monograph side, but personally, I don't think that's going to be an issue. And I'll explain why personally I don't think that's a problem. Like I said, buprenorphine has a ceiling effect. So if you're adding, buprenorphine on top of the buprenorphine that they're receiving from the extended release, I'm saying buprenorphine a lot. When you add it on top of the LAI, I don't think from a safety perspective, you're really going to put the person at much harm, especially if they're coming from fentanyl. You're trading down in opioid potency. Buprenorphine is not as potent as fentanyl for one, and it has that ceiling effect. So if you're just adding buprenorphine on top of buprenorphine for somebody who was previously on fentanyl, I don't personally see that there is a risk. So sure, if you wanted to do that because it may help them with their, we'll call breakthrough withdrawal symptoms, I think that's a decent approach.
Okay. And there's so many, thank you. So many questions, such great answers. What questions do you have me? Okay. Oh, so there's a question around speaking to early injections at 3 weeks. And I actually had a question about that when you were mentioning that. I actually had a patient the other day who I wanted to give an injection to on day 24, but the pharmacy wouldn't fill it. He was on ODB saying that, according to the LU code, it can only be filled every 26 days. And so even though I'd called him in, I had to, or I can't remember, maybe it was 22 days, but whatever it was, they said they had to come back 4 days later. And so even though I had spoken to him on the phone and said, sure, come on in, let's just do this earlier. And I did end up giving him a lot of sublingual Suboxone just to kind of help him over the next few days. But I'm just sort of wondering about if there are any workarounds or any suggestions you have around that, because I've had some pharmacists fill it and some pharmacists saying, no, it's too early.
But before I go into that, okay, yeah. So I'm just going to bring this up for context because you mentioned the LU code. 1 second here. Let me just open up in a different window here. Boom. Okay. Okay, here we go. So yeah, this is the LU code right here. So when you are prescribing, it's just a good idea to write that in general so it does get covered for the patient, especially if they're on ODB. It does mention that there's a minimum of 26 days required between consecutive doses, but this is based on the clinical trials. I'm not totally sure then that if they were to dispense it early, that this would be a problem. So I think it's definitely worth having a conversation with the pharmacy in that regard. But let's just talk about it clinically speaking. I don't think it's a problem if you give it earlier than 26 days. If you give it as early as 24 days or 21 days, I don't think it's going to be a problem. Let's just put it into context though. They're not getting the early injection because they want it. They're getting it because they're going into withdrawal in the first place. So there is a need. They're likely going to withdraw because they came from a more potent opioid. Their receptors are maybe a little bit less stable, hence why they're feeling the withdrawal symptoms early. And you're topping up again with a partial agonist with a ceiling effect. And so I'm not concerned from a safety perspective that by giving it early, you're going to cause respiratory depression and a overdose. So my opinion, if I was the pharmacist in that position and I was given a prescription to give, buprenorphine XR 2 weeks later, I wouldn't hesitate.
Thank you.
Yeah.
I have a question that's not up there. It's around the TRANSFORM trial. The risk of serious adverse events was fairly high. It was 20%, and the test dose that was given was 4 milligrams with a CAS score greater than 8. I'm wondering, like, my practice is I actually give a much higher dose because I want to actually risk avoiding precipitated withdrawal. So for me, if somebody had a CAS score, maybe not 8, but maybe 10 or 12, I would be giving 16 milligrams, waiting an hour, giving another 16 potentially, and then later that day giving the Sublocade, or sorry, the extended release buprenorphine injection. So I'm just wondering, that 20% is fairly high. And what do you think about actually using a higher dose as not a test dose, but just to just check to make sure there's no allergy? And there's another question in the chat too about what is the actual incidence or prevalence of a true buprenorphine allergy, and do we really need to worry that much about it?
In terms of true buprenorphine allergy, I can honestly, I've never heard of it. Both during my time with Indivior and as a pharmacist, I've never heard of that, to be honest. So I think, to be honest, the reason that they put that from a study perspective is just because it's a more formal process, just to understand that before you're going to give somebody an injection with a active ingredient that will last a whole month, you want to ensure, at least by using a more acute lasting dose, that you're not going to cause an anaphylactic reaction. I think that's really just the reason why they did it. In terms of your first question, though, what was it again? So you said.
Oh, well, just in the TRANSFORM trial, they're using 4 milligrams, but their risk of serious adverse events, or whatever they called it, they don't specifically say precipitated withdrawal, but the symptoms described sort of are consistent with that, and it's as high as 20%. And I'm just sort of wondering about people being, like, whenever I've had somebody who's got those adverse events right away, they are turned off with buprenorphine, and it's hard to get them back on. So I'm just wondering, like, my practice is to use much higher doses, and I'm just wondering what your thoughts are on that. And
okay, yeah,
TRANSFORM trial, or if there's another trial going on, you're going to use higher doses.
I think that the intention of that 4 milligram dose isn't the same as your intention of giving 16 milligrams, right? So the 4 milligram dose that they're just doing is just for the testing purposes. But I think from a practical aspect, what you're saying makes a lot more sense. You're trying to achieve not just safety, but you're also trying to achieve comfort for the patient so that when they do transition to the extended release version, that they're going to feel confident about their treatment. And I think from a practical aspect, that actually makes more sense.
So there's a bunch of questions. I apologize if I didn't get to somebody's question. There's a question from Dale here about pharmacists giving the injections themselves, and for physicians who are doing telemedicine, and that's being a bit of a barrier. And are there any sort of solutions or plans in place for, I guess, funding for pharmacists to provide the injection?
Yeah. So I mean, this differs province to province. In Alberta, this has never been an issue. The scope of practice there has allowed pharmacists to be injecting subcutaneously for a long time. In fact, from what I understand, many patients who receive Buprenorphine out in Alberta get it from their pharmacist. Ontario, less so because of the scope of practice being so restricted. However, there are workarounds. So I personally know a few pharmacists that have been able to inject Buprenorphine in the setting of their own pharmacy. The way they're achieving this is with a medical directive. And I think in order to actually get a medical directive going, this is where it's really important to have a good relationship between, the physician and the pharmacist, just so that the physician knows who they're trusting to give those injections or who they're trusting to administer those injections. It is worth noting, though, that in July of this year, the scope of pharmacists did expand in terms of providing subcutaneous injections. If you look at the list, though, buprenorphine is not one of the ingredients or one of the APIs that is allowed to be injected by a pharmacist. However, I am hopeful, and I have spoken with somebody on the college board of directors here with the Ontario College of Pharmacists, and they do say that it is a plan. It's just I think it's more of a matter of time before that actually happens, but just currently that's not the case.
Well, thank you very much for such an informative and interesting talk. It's 11:31, and I know there are networking sessions, and everyone wants to get to that. So thank you, Ainko, and thank you for everyone who attended. And I'm sorry if I didn't get a chance. There were so many questions, and I'm sorry if I didn't get to yours.
If you have any other questions, just DM me in the chat, and I'll give you my contact info. We could talk personally then.
Great, thank you very much. And oh, and don't forget to fill out. I just put the link to the evaluation for today's talk, if you can kindly fill that out, and hopefully you can all make it to the networking session that's starting now, and that's followed by an hour break for lunch, and then there'll be the afternoon sessions. Okay, thank you,
Anita.
Thanks. Bye-bye.